Welcome to this module on person-centered language for leaders in acute care settings. In this module, we will 1. Explore how power is implied through language, and 2. Define person-centered language. Desmond Tutu once said, "Language is very powerful. Language does not just describe reality. Language creates the reality it describes." So, what is person-centered language? Person-centered language is language that is specific, objective, and respectful. Let's begin by learning more about this definition. Let's explore person-centered language in a bit more detail. Person-centered language is specific. This means writing a brief description with precise details on the who, what, where, and when something has happened. Using specific language allows other team members to easily understand what you are describing with less room for misinterpretation. Specific language enhances our ability to plan and evaluate patient care. It enables the team to implement interventions and evaluate their effectiveness through the use of clear details that are not open to misinterpretation. Person-centered language is objective. When we use objective language to describe our assessment findings, we use observable or verifiable facts and not personal opinions. What we write will influence the next clinician who interacts with this patient. The words used in a patient's chart will become an enduring part of their health record and influence the care they receive. Person-centered language is respectful. This means using language that avoids labeling or infantilizing the patient. The language we use can promote, empower, and increase self-esteem, or it can demean, devalue, and disrespect those it refers to. Using specific, objective, and respectful words when we communicate with older adults means our conversations don't condescend or infantilize. Through our language, we can demonstrate a recognition of identity, personhood, and respect. Let's stop for a moment to consider the impact of words. Why do the words we use matter so much? Many things are conveyed through our choice of words: power, dominance, judgment, bias, positive or negative. The words we choose matter greatly. They can create biases or preconceived ideas about our patients. The words in the center of this slide have a negative bias and make it seem that the patient is inaccurate, lying, malingering, or misleading the care team. Phrases such as failure to cope or frequent flyer imply that the patient is at fault. These words and phrases are used so often and in so many places that their impact is significant. Many health professionals are unaware of the bias and judgment conveyed and the impact of these words. There is an inherent power dynamic in healthcare, with the healthcare team typically having the greater balance of power and dominance. Our language reflects this. When we speak of patients claiming or denying a symptom or experience, we are casting doubt on the truthfulness of their words. We are inferring either inaccuracy or intention to mislead. Terms such as non-compliant or poorly controlled also reflect the power dynamic and cast the patient as a lesser part of the interaction and one that is not pulling their weight. Think about the words typically attributed to the healthcare team: orders, protocols, plans. These words carry weight, importance, power, and dominance. The first step towards a more person-centered way of thinking and speaking is to become more aware of power dynamics and how they are reflected in our language. Something to think about. Which of these two statements have you heard more often? Patient claims pain is 10 out of 10, or doctor claims to have heard S3 heart sound. Why is this? Because the words we use reveal who has power and who does not, who is to be believed and who is not. The key point here is that words reveal power and dominance. Studies have shown that two main factors affect the burden of stigma placed on a particular disease or disorder: perceived control that a person has over the condition, and perceived fault in acquiring the condition. When we believe a person has acquired their illness through no fault of their own, and or that they have little control over it, we typically attach no stigma to either the person or the illness. For example, advanced metastatic cancer or end-stage renal disease. But when we perceive that the illness or behavior is under the control of the person, we feel that they are at fault. For example, substance use disorder or responsive behaviors of dementia. Have a look at the admission diagnoses listed on the right-hand side of this slide. Which ones convey perceived fault or control over the illness or disease state? The perceptions of fault, control, and blame are higher for poorly controlled diabetes, dementia, challenging behaviors, and confusion, failure to cope. In each of these, there is an underlying assumption that the person is at fault, not doing their best, and is less worthy. The perceptions of fault and control are lower in the diagnoses grade 4 left ventricle end-stage cardiomyopathy, metastatic ovarian cancer, and exacerbation COPD. In these diagnoses, the language used is free from bias, judgment, or stigma and implies that the patient is less able to control their illness and is less at fault for their current medical situation. The stigmatizing, labeling, and blaming words poorly controlled, challenging behaviors, and failure to cope imply that the patient is at fault and hasn't done what they were meant to do. Think for a moment on how you might word those admission diagnoses differently. So, what can we do? We can use person-centered language that is specific and objective language instead of sensational or fear-based language. We can avoid words that make it seem as if the patient is unpredictably volatile or a threat. We can be aware that some labels and language may induce explicit and/or implicit biases, and that language that belittles or blames the patient has negative impacts on the therapeutic relationship. When we use labels, we talk and think about things to be managed instead of people to be understood. Using person-centered language in healthcare is one way of addressing the individual impacts and the beginning of a revolution in how we think and provide healthcare. The key point is that we can harness the power of language to reflect our thoughts and feelings in a person-centered manner. Person-first language helps us to see the person, rather than only the diagnosis, and helps to reduce the potential for stigmatization. Introducing the person first and the condition or disability second suggests that the person has a problem that can be addressed, rather than implying that they are the problem. So instead of dementia patient or demented patient, we would say person with dementia. Instead of substance abuser or drug seeker, we would say person with a substance use disorder. Instead of COVID patient, we would say person with COVID. When in doubt, ask the person what they would prefer to be used to introduce or describe them. Our person-centered language challenge to you. Over the next week, challenge yourself to use person-centered language when discussing patients on the bed utilization call and during daily huddles. When you hear non-person-centered language being used, ask for clarification and additional details. Then, rephrase using person-centered language. Describe using specific, objective, and respectful language to help your colleagues and teammates work more effectively with the patient. Key point: words matter.